A lot of what I'm going to present to you today is from the World Malaria Report. This is sort of our flagship document that we produce once a year. This is the cover of this past year's report. It comes out every year in December. This year we're very fortunate to have President Ellen Johnson Sirleaf of Liberia launch the report for us in Monrovia in December. So one of the things that concerns us, and you can see up here, this is international funding for malaria. You don't need to see the different bars. Some of it's Global Fund, some of it's USPMI, some of it's the World Bank. But you can see that we went from very little funding in 2000. And when I last talked to you in 2011, we were sort of smugly talking about this ever-increasing curve. And I think what's really concerning to us is when we look at 2012 and 13 and then project out to 14 and 15, that's a plateau. And that's at about $2 billion. And while that's a lot of money, and more money than any of us could have imagined in 2000 going into malaria, that's very short of the $5 billion a year that we estimate we need to have universal access to very basic life-saving interventions. So it's a bit of a good news, bad news slide. It's a lot more money than we had, but a lot less money than we need. And so what have we bought with all that money? They're really the core malaria control interventions, and for many of you this is an obvious review, but for those of you that are not living and breathing malaria every day, it seems important to go over it. So bed nets, upper left, indoor residual spraying, rapid diagnostic tests, that's in the middle, someone getting a rapid diagnostic test, and artemisinin-based combination therapy, or ACTs, which we've had in place for just over a decade. And these basic life-saving interventions have really changed the picture of what's possible in malaria control. And so where have we gotten with that? These are deliveries of bed nets. And what I want you to look at is the shape of this interesting curve, because we were doing very well until 2010, right? And that peaks at about 150 million bed nets delivered in 2010. That's a pretty astonishing number. A bed net is not a small item. 150 million bed nets is very, very impressive. But if you look at 2011 and 2012, we are not keeping up that sort of distribution. The average long-lasting bed net today lasts 3 years. So it doesn't take a lot of math to figure out, unless 2013 is a banner year for distribution, we could have a serious problem on our hands. Because what happens when bed nets wear out, and we have good examples of this, are phenomenal resurgences in malaria that can happen very, very quickly. You can actually undo a decade of progress in malaria control in a single transmission season, right? And sometimes we're talking with the Global Fund, which does HIV, TB, and malaria. We have to remind them that a vector-borne illness like malaria is a fundamentally different thing, and that the ups and downs of funding can't happen, that we have to smooth that out. That has to be more predictable. So that's a lot of bed nets, but it's still a long way from achieving universal coverage. This light-colored line, which peaks out at about 55%, is the estimate of households that have at least one bed net in sub-Saharan Africa. And the darker line is those sleeping under a net the night before. It's about 33%. And while those are very impressive increases over near 0% at the beginning of the decade, that's a long way from universal coverage. And no matter how much spin you see out there, we have distributed enough nets to cover each household, maybe. But the reality is we're not there yet. This work, by the way, is work that we do together with IHME in terms of estimating, because it involves taking distribution and household surveys and a lot of complex modeling that I don't entirely understand. So this is actually model work that we do together with IHME. Diagnostic testing. For me, this has been the most important change. And I've talked to those of you that have seen me talk here before know that this has been sort of my signature issue. And I want you to look at that dark line on the bottom. And this is proportion of suspected malaria cases in public health facilities only getting a diagnostic test. And that has gone up from near 0 up to about 45% of suspected cases getting a diagnostic test. That is a very impressive increase. That's a real paradigm change from presuming that every fever is malaria to getting to the point where every fever should be tested with malaria. And I'll circle back to that from an advocacy perspective later. You can see that in much of the rest of the world we've already gotten there, and that universal diagnostic testing is more or less a reality, but we still have a ways to go in Africa. Again, you can see this concerning plateau. If I go back a slide, you can see that we were going up and up, and then 2010, 11, oh sorry, those numbers got mixed up on the axis down there, but 11 and 12, there's not much progress. And you can see this throughout all of these slides, that we're getting a little bit of plateauing. And if that plateauing were up at 80, 85, 90%, great. Plateauing at 40, 50% is not acceptable. The other thing that's very important to us is that diagnostic testing offers this incredible opportunity to actually do a better job of surveillance around malaria. But if you think about this, and we were talking about this a little bit this morning around the cascade, the bottlenecks. So if there's 100 actual malaria cases out there in the world, this is sort of what happens, and this is why we really only get to about 10% of them being reported. Let's say 80% of those seek treatment. About half of those are at a government health facility where we have a prayer of collecting the data, and at those, it's not necessarily part of the surveillance system, and they may not all be tested, and then those individual cases may not all be reported. And by the time you're done with that, those 100 actual malaria cases out there, there's only 10. And this puts us in the pickle of having to do an awful lot of estimation because the surveillance data that we get is inadequate in so many places. And so what are those bottlenecks in case detection? You know, this is by region, and I'm not going to go through each of those. But in Africa, you can see that, you know, actually from cases, which is the blue, to seeking treatment, a lot of people seek treatment. A fair proportion of that in public sector, although that's very different in different countries. But then there's a huge drop-off still to tested in many places, right? And so, but we need to be working on all of these if we want to get to the point that people have access to testing, have access to treatment, that it gets reported. You can't just be working on one piece of this puzzle, or we're never going to get to where we need to be in terms of knowing where the malaria burden is. So if we stand back and look at trends in surveillance systems, there's two types of diamonds up here. The dark ones, we're actually able to assess trends. The light colored diamonds, we can't assess trends. And on the x-axis, we have the estimated number of malaria cases. And the y-axis is the proportion of cases that are detected by the surveillance system. And what you can see is that the higher the burden, the higher the number of cases out there, the countries where we most need to know what's going on, we actually know the least, right? So the Nigerias and DRCs of the world, which together make up 40% of the world's burden for malaria, are the sort of countries we find out here, and we actually don't have surveillance systems that can tell us what's happening in those countries, right? So, you know, we've set very ambitious global targets for ourselves in terms of malaria. We've said that we're going to reduce the malaria burden by 75% by 2015. And I want you, these are codes for the WHO region, so AMRO, also known as PAHO to most people, EMRO, Europe, Southeast Asia region, and the Western Pacific region. I want you to focus on the far left, Africa, because of course that's where the main malaria burden is. And you can see 8 countries are on track for a 75% reduction, right? And 32 countries, that light part of the pie in Africa, we have insufficient data to assess trends. So only by estimating and using models can we even determine what we think is going on. We can't measure it directly, right? And so if we look across these countries, there are 50 countries that are on track. God, that sounds great. Out of 99 countries, half of them. But those half make up only 3% of our total estimated cases. So it's great, pat ourselves on the back. It is great progress. And country by country progress is a great way to build momentum. But if we want to be serious about it, we have to make that sort of progress in the big countries, and we're not there yet. So if you look at progress in reducing cases in relation to initial malaria burden, this is the reported number of cases in 2000, and this is the change in malaria case incidence rate. So you actually want to be down here, which is a 100% decrease in cases. In a few places, we've actually increased in cases. That's very bad. But if you look at this axis from sort of less than a 25% drop down to a 100% drop in cases, you can see that the higher the burden, the less progress we've made in terms of proportional drop, right? So proportionally, we're doing better in the smaller countries, which isn't a surprise. These are countries that have better health systems. It's easier to measure what's going on. And in general, we've had a higher per capita investment in smaller countries. But, very important message, this is the flip side of that message, is that while the progress has been faster, so the proportional decline has been faster in the smaller countries, the overall number of lives saved is higher in the big countries. So we're doing great work. A 25% drop in burden in a very big country is an awful lot of lives saved. But the point is, if we could get that proportional coverage up, that proportional burden reduction to be greater, of course, those number of lives saved could be all that much greater. So these two types of diamonds here, the African region are the dark ones. The other regions are the sort of tan-colored. And you can see the estimate. Let's just look at the deaths. This is estimated number of deaths on the x-axis, and the estimated number of deaths averted. And you can see that the higher the burden in 2000, the higher the number of deaths averted. So it's not that nothing's happening, right? We don't want this to all be a bad news message. Good things are happening in these big countries, but just not enough of it. We're not at scale. I'm going to show you, these are new. This was just done a week ago. I did this for a meeting that I was going to in Oslo. There's a Lancet Commission on Health that's looking at what could we achieve between now and 2035 in infectious diseases amongst some of their other tasks. And for that, I sort of wanted to animate what had happened in the last 10 years. So this is global malaria incidence rate, and the darker the color, the higher the incidence rate, so red being the highest, Africa, not surprising. And I'm going to press play here, and it's going to go from 2000 to 2010. Pick a part of the map to focus on, maybe Africa. And I think what you'll see is not much has happened. It flickers around a little bit, and outside of Africa, we're dropping it. But overall, the incidence rate isn't changing that dramatically. It goes up and down. Maybe it's a little more green in some of the peripheral. Africa is still pretty red at the end of the decade. So in terms of number of cases, we're still struggling with the case rate. But what is impressive is that we are preventing people from dying. So these are malaria death rates, right? And again, same sort of color scale, where the darker the color, the dark red is the worst. And if you look at death rates from 2000 to 2010, you can see that there the map really is shrinking, and that by the end of the decade, there's a lot less red out there. We actually really are saving people, stopping people from dying, which we should. We don't actually have the tools to get to elimination in the heartland of Africa or to get to eradication today. But we do have the tools to stop people from dying from malaria. This is not rocket science, right? A bed net, a 50-cent diagnostic test, an antimalarial treatment. These are basic things. What we lack are the resources and systems and people to get it out there in many places. But we have made progress over that decade. And so what does that mean globally? Well, these are estimates. And we say that we've had a 25% decline in malaria mortality rates over a decade and a 33% decline in the WHO African region. Again, estimates, right? So you've got to take those with a grain of salt. And that we add that up, and many groups have actually looked at this number of lives saved. And what's amazing is the groups have all come up with a very similar number, which makes you feel a little better about it when it's not just one group. And that's about 1 million lives saved over that 10-year period. That's a lot of people. It's a lot of kids. Most of those are kids. But that still leaves a pretty darn large public health problem. That's still 219 million cases worldwide. That's wide uncertainty intervals around that, 154 to 289 million. And about 660,000 deaths with a pretty wide uncertainty range around that, from 490,000 to 836,000 in 2010. And that's entirely unacceptable for a disease that's preventable and treatable. And actually, I put this up there because, someone said, well, you should put that on a log scale. I'm like, no, it's intentionally not on a log scale. Africa's on the far left. Yeah, we need to continue to make progress outside of Africa. But this pretty much hammers it home, that unless we get the burden down in Africa and in kids under the age of 5, which is that light blue bar, that's where the lives need to be saved, right? It's under 5s in Africa. And if you look at these sort of SAIL diagrams, on the left are cases and on the right are deaths. And these are these are country-specific estimates that we put in the 2012 report, although it's 2010 data are the last country-specific estimates we have. And you draw a line at 80%. 14 countries make up 80% of the deaths worldwide. And as I mentioned before, 2 of them, Nigeria and DRC, make up more than 40% of the deaths. All of the leading countries for deaths are in Africa. For cases, it's 17 countries, of which 15 are in Africa. India and Indonesia are 2 of the countries that come in terms of case counts. It won't be lost on you, those of you that have paid attention, that we had some differences of opinion about the number of deaths globally. Some of the gray hair that I have, I would attribute to the several weeks around the controversy that emerged around this. I guess what doesn't kill you makes you stronger. But actually, I really think, all joking aside, I think the news stories really botched this one. The real news story is that actually, for most of the estimates, they're indistinguishable statistically. If we look at under 5s in Africa, outside of Africa, yeah, the point estimate may be different, but the confidence intervals overlap. The real story is through 2 different methodologies, we have a real difference in kids over 5 and adults in Africa. And there's a question that we have to answer. Which is this? Is there really a much larger group of deaths in over 5s and adults in Africa that we, WHO, are missing through the methodology we are using, or not? And so we have been meeting. So we have an evidence review group that's supporting us to look at our burden methodology, which we do all the time. We're constantly revisiting it. And actually, we had Chris Murray out this year for a whole day as we talked through this. And I think we're all committed to sort of trying to do some of the studies that will answer this question. This is an answerable question, right? How much are we missing? You know, how big a problem is the number of deaths in adults and older children in Africa? So stay tuned. Don't have an answer to this yet, but I wanted to put that in a little bit of perspective and say that we are all working together to try and figure that out. We're talking a lot about Africa. Mapping is a very powerful tool. This is from the Malaria Atlas Project, which is based at University of Oxford. And this shows the basic reproductive number for malaria. And to actually get malaria to go down, you actually have to get less than 1, right, if you're going to have a spiral downward. This graph, this sort of a heat map graph, shows the darker purple is very high. And if you'll cast your mind back to the maps I showed of the progress, you'll see a pretty serious overlap with the red places of where where incidence rate remains high and death rates remain high, and this part of Africa. Intrinsically, biologically, given the vector and its ability to transmit, we have a problem in that part of Africa that we do not have the tools to actually eliminate malaria from that part of Africa today. We can stop people dying, but we don't have the tools to get rid of malaria. This is a slide I borrowed from Malcolm Molyneux. Some of you may know Malcolm, many, many years of working in Malawi, wonderful, wonderful clinician and researcher. And this just shows that, we talked about those fatal malaria cases, and this is all just visualization. Don't take this at sort of actual case numbers. But life-threatening cases sort of are below that. We don't have a very good estimate. We have febrile illness. What I want you to concentrate on here is this yellow, because increasingly I think we're all saying, if we're really going to tackle malaria, and we're going to actually drive down transmission, what are we going to do about this big yellow part of the pyramid? What are we going to do about all those people out there who are asymptomatic, who our current paradigm isn't going to get rid of the parasites in those people? And how do we make progress in that? And stay tuned. There's a lot of thinking going on around that now. The other problem, and this gets back to what I was talking about before, we only know this tiny slice of that pyramid, right? This is what's known to health services and reported, right? We give the example of developing world where, of course, malaria is a big deal. You get a malaria case in Seattle, everybody knows about it, right? We get most of the cases in the United States we find out about in the reporting system here. I do not want this slide to get out there. So if we're going to post this anyway, I'm going to delete this slide from whatever's posted. But I did want to share it with you as a university community of which I'm a part. I did this, did some work a few weeks ago with the Imperial College Modeling Group. This is Azra Ghani's group in Imperial. And we did this for the Lancet Commission on Health, trying to say what could happen between now and 2035, right? And I want you to look, the red line would be disinvestment today. We stopped doing everything. And these are lives that would be, these are just cases. So this is what would happen to the cases per 1,000 population if we disinvested today. It would shoot back up. Wouldn't take very long to lose the ground in what we've done. The blue line is the sort of what happens if we continue at the current pace of what we're doing. It's the green line that's very interesting to me, and I don't know yet. This is modeling, so we don't know if it's right. But if we were to get to 80% LLIN coverage, truly 80% of people who need it covered with an LLIN, and 80% of those people with access to an ACT when they're symptomatic, what happens is we do well through about 2016. And then things start to fall apart slowly, and we get this creeping back upward. Because right now we are being partially helped by partial immunity, right? People do develop not complete, but partial immunity to malaria. As we are successful, as we drive down transmission, we lose that beneficial help from partial immunity. Now that's not a reason not to act, right? The current status quo is not acceptable. People are dying. But it does suggest that just doing what we're doing today isn't going to get case counts down. Now, deaths is a different matter because we can reduce case fatality rate in malaria to 0 with the tools we have today. But actually getting after transmission and getting transmission to stay down is going to take additional efforts that I think is going to take a lot of thinking and strategizing and research. And for those of you that are looking for careers in something to do, understanding the burden of asymptomatic malaria and what we're going to do about it, I think is going to take up much of the next 10 years. What does the Global Malaria Programme do? And those of you that have seen me talk before know this, but for those of you that don't, it seems important to explain what are we doing out there at WHO. And so we have 4 core roles in the Global Malaria Programme. Our first is a normative one, which is to promote the adoption of evidence-based norms, standards, policies, technical strategies, and guidelines. That's what most people think of when you think of WHO. That's our most important thing. We convene experts to set policy. We keep independent score of global progress, and that word independence is very important. We don't have a horse in the game, right? We're just out there to do it. That's what the World Malaria Report is a good example of. We develop approaches for capacity building and system strengthening and surveillance. Now, we don't have people everywhere, so we're not running around doing this, but we develop sort of templated approaches for this. And then we identify threats to success and opportunities for action and try and catalyze those. One of the things that I went to WHO to do was to rebuild the policy setting for malaria, which had become a bit ad hoc in recent years. And we convened a group of experts to advise us on how we should do this. And in the end, we chose a model of SAGE. Some of you work in immunizations. If any of you work in immunizations, you'll know SAGE. It's the Strategic Advisory Group of Experts. And we actually modeled the new malaria policy setting process at WHO on SAGE. And so it's called the Malaria Policy Advisory Committee. It's 15 people who were selected in an open nomination process from more than 100 who applied. That's the picture of the current committee. And we meet twice a year, largely in open session except for the formulation and final wording of the recommendations. It's open to everyone. The documents are publicly posted. And within 2.5 months at the end of each meeting, not only is the report of the meeting on our website, but it's actually published in the Malaria Journal, where it's accessible on PubMed and people can find it easily. This is complicated, and there's no quiz on this, but it is a complicated process. Setting policy is not easy. It involves interfacing with a lot of different groups. The MPAC is the dark orange in the middle of this. And we have some standing committees with things that are going to never go away. The issues of vector control, chemotherapy, drug resistance, surveillance. These are issues we need standing committees that report to that MPAC. For other things, we convene evidence review groups, time limited. What's a new policy for malaria and pregnancy? Convene a group, review that over a couple meetings, make a recommendation to the policy committee, the Malaria Policy Advisory Committee, disband. When you need a new topic, convene a new group of people. We have some things we do with other departments. Malaria vaccines, obviously on many people's minds. I'm actually not going to talk about that today. But we have a committee, the Joint Technical Expert Group, which we do together with the SAGE, with the immunization department. A few things that are key, and this one I've actually shown before here, but we do have a big problem out in the Mekong with the development of artemisinin resistance, which meant we now have 4 countries where we have artemisinin resistance, and we have a global plan to tackle that called the Global Plan for Artemisinin Resistance Containment. We don't want this to happen. This is a slide from folks at NIH many years ago, but this is what happened with chloroquine, right? Started in the Mekong and spread worldwide to the point that we lost chloroquine completely. And much of the increase in child mortality in the 1980s and 90s, there are many reasons, but one of the reasons in Africa certainly was the loss of chloroquine efficacy. And the problem is chloroquine is a very powerful antipyretic. And so that masked the fact that it was actually losing its efficacy because people feel better when you take it. It breaks your fever. It wasn't killing any parasites, right? So that hid the problem for many years. But we don't want this to happen with artemisinins. That would undo a decade of progress. So we actually have a problem in 4 countries, in Myanmar, Thailand, Cambodia, and Vietnam. The areas in 1 are Tier 1. That means areas we actually have resistance, the dark color. Tier 2 are neighboring areas. And these are places where we're actually mounting containment programs, very aggressive programs to find people with parasites and get rid of those parasites. But it's challenging. If you notice this map, it's the same thing everywhere. It's a border problem. And there's a reason it's a border problem. It's hard to find people. These are borders that are porous, where there's conflict, and it's hard to find people, and people have poor access to health services. So this is the problem. The place we most need to reach are the very places that are most difficult to reach. We're launching, this is the first time I've shown this publicly. I just got this yesterday, last night by email. This is the cover of the emergency response to artemisinin resistance in the greater Mekong subregion. This is a plan, a multi-country plan that's going to be launched next week in Phnom Penh on World Malaria Day. Princess Astrid from Belgium, who's a champion of malaria, will be coming out to launch it with us. And we have the countries signed on to this plan. All the countries have actually signed on to this to combat this problem, because this cannot be done well in one country and ignored in another, or you've lost the whole battle, right? And fortunately, the Global Fund has understood the importance of this regional collaboration, and they've put $100 million in the new funding model into fighting artemisinin resistance in the Mekong. We also have a problem with insecticide resistance. So, our enemies are constantly outsmarting us. So here we have a problem of drug resistance in the parasite. We have a similar problem of insecticide resistance in the Anopheles mosquitoes. We have insecticide resistance in 64 countries and counting. And that led us to have, last year, release a global plan for insecticide resistance management, which we released in May of last year. And the point is, of course, to maintain the effectiveness of current vector control methods, right? We can't lose pyrethroids. Right now, there are 4 classes of public health insecticide: pyrethroids, carbamates, organophosphate, and organochlorine. Organochlorines is only one, DDT. If we lose pyrethroids today, they're the only ones we have on nets, we have a serious problem on our hands. So we have to make sure we don't let that happen. We have some opportunities ahead of us. We talked a little bit at HI about this morning, but integrated community case management, or bundling together malaria, care for malaria, pneumonia, and diarrheal disease, represents a phenomenal opportunity. These are the big childhood killers. If you take away neonatal deaths, almost all the other deaths are due to those 3 killers, right? And so we are working very hard with countries to roll out a package of diagnostic testing, antimalarial treatment, antibiotics for pneumonia, ORS, and zinc, with referral for those who are sick or don't have one of these things. There is a movement afoot now to train 1 million community healthcare workers. But as Steve and I talked about this morning, and Kenny and I talked about, the problem is, how do you motivate and pay those people? There are good systems, like Ethiopia we talked about, where there are 30,000 health extension workers on the government rolls. But in many other places, these are volunteers, and it's been very hard to maintain those. How many times have, as Steve was saying, the APEs in Mozambique have gone through several boom and bust cycles over the years. And so the trick is, how do we do this, but figure out a model where it's sustainable and actually the government owns these projects. It's not a project. Elimination. Obviously, the real way to deal with malaria ultimately is to eliminate it in country by country and get to global eradication. Those stories are complicated. In many cases, elimination has come close only to fail. Sri Lanka at some point was down to under 100 cases, and then it went up to the hundreds of thousands, millions of cases. So we're trying to learn lessons from those experiences. What have we learned? And we're working with the Global Health Group, with UCSF, and the countries, in 10 countries, to actually document in a very detailed, these are very detailed reports that really tell the stories of where things have gone right, how they've gone wrong, and how countries are eventually getting to the point of elimination. There's 4 that are out already, and there's 6 more coming out this year. I've talked a lot about the importance of diagnostic testing and surveillance, and as I've said, that's sort of been my signature issue. And I just showed, for the first time when I was here last time, we had just gotten the logo, and that was October 2011. And we since then have launched this global campaign called T3, or Test, Treat, Track, saying that every suspected case of malaria deserves a diagnostic test, every confirmed case should be treated with a quality-assured antimalarial, and the disease needs to be tracked in a surveillance system. So this does not sound like rocket science, but getting people to pay attention to this part of the malaria fight, as opposed to just thinking it's all bed nets, has not been easy, right? And so the idea was to raise the profile. Dr. Chan is the Director General of WHO, launched this for us on World Malaria Day in Namibia last year. And this is the Minister of Health of Namibia, Richard Conway, who's a malariologist. I'm always very happy when a malariologist gets appointed to be Minister of Health. Makes my job much easier. And these are the partners that have signed on to support this effort so far. Many more since, but at the time we launched it. On the same day, we launched new surveillance guidelines. This stuns me. These were the first updated surveillance guidelines for malaria since the Global Malaria Eradication Programme. WHO had gone 50 years without updated surveillance guidelines for malaria. And frankly, without surveillance, we're just flying blind. We have no idea what's going on out there. We can argue about models. We can trade estimates in the press. That doesn't help a program manager on the ground at a district level. Only surveillance does that. And so we are making a big push to use the advent of diagnostic testing as an opportunity to get surveillance right. So what lies beyond for malaria control and elimination? So there's a lot of technical documents in the works, but there's 3 things that are out there in the next few years that I really want you to know about. Vivax. It doesn't kill a lot of people, but boy howdy does it affect a lot of people globally. There are a lot of people at risk of Vivax, and it's a much more difficult technical problem because there's a latent liver stage, a hypnozoite. It makes it much more difficult to tackle. And when you have countries where both species coexist and you beat down falciparum, usually Vivax rises as a proportional problem. Often Vivax in our documents is an afterthought. We're like, oh gosh, we're going to publish in 2 weeks. We don't have a Vivax chapter yet. Somebody got to write a Vivax chapter. So this time, we're actually starting with Vivax, and we're actually developing a global Vivax strategy over the next couple of years. And that's going to feed into a very important document that we've just started, which is a new global technical strategy for malaria control and elimination for the post-2015 era, 2016 to 2025. And that document will be the foundational document for the new Global Malaria Action Plan, which is the advocacy partner harmonization document that the Rollback Malaria Partnership will develop. And those three things are all going to emerge over the next couple of years and take up a lot of our time and are very, very important things. I just put this out there because I am talking to an academic community here, and for those of you who are looking for research projects, I think the things that are most important in research in terms of things to think about over the next few years, and this is a mix of product development, basic science, field research, so it doesn't matter what you're interested in, there's something up here for you. Transmission blocking tools, whether those are antimalarial drugs, vector control, or vaccines. Highly sensitive field-ready diagnostics. I talked to someone in Rio in a meeting a few months ago who said, yeah, I can make you a fluorescent RDT reader that will be web-enabled and transmit those data. And I was like, how much would that cost? Those are sort of things that could change the game if they were cheap enough. Mass treatment or mass screening and treatment options. In the past, there's been a lot of skepticism of those, and there's a good reason to be skeptical. But we need to understand more how we could use tools like that if they were safe enough drugs to drive down transmission. Safe, short-course gametocytocidal drugs, drugs that will kill the sexual stage of the parasite, going to be very important. Optimum delivery systems for all these tools, and building capacity to use data for decision making, right? Something I think we talked a lot about this morning. There are a lot of extrinsic challenges to malaria out there. The biggest is money, right? This is work that was just presented last week at the replenishment meeting for the Global Fund in Brussels. The Global Fund is asking for its 2014 to 2016 replenishment $15 billion. A lot of people say that's a lot of money, and I guess it is. But it's certainly not a lot of money if you compare it to what we spend on military spending and other things, is it really? It's a pretty small price to pay for what we're getting out of the Global Fund. And this is the malaria piece. 90% of what we need in terms of billions of dollars is for Africa over those 3-year periods. $6 billion we need for Africa. That's the gap over those 3-year period. Asia, about a $0.6 billion gap. So we have a lot of need out there between that 2014 to 2016 period. Because really the greatest threat to us in malaria control today, or over the next few years, isn't a biological one. Yeah, there's drug resistance, there's insecticide resistance, those are real threats. But the biggest threat is not having enough money to keep up the progress that we've made to date. And it could be very quickly undone. What are some of our other challenges? I talked about this with relation to artemisinin resistant. Migrant and mobile populations. We're an increasingly mobile world, and people travel with their parasites. And finding those people and getting them access to healthcare services is not just an issue for malaria, but an issue for so many healthcare issues. And we need to figure out how to do that better than we're doing today. These are migrant workers in Thailand and Cambodia. Climate change. You can dispute what the cause of it is, but I don't think anybody's disputing the fact that it's happening, right? Tell this polar bear it's not happening, right? And we could do a lot of modeling to imagine what that will or won't do to malaria. And I'm not sure how valuable that is. But the bottom line is if we have systems in place that are good surveillance, then we'll promptly identify where that burden is changing and be able to react to it. We're going to be in an ever-changing world, and we have to be ready for that. Urbanization, I was stunned when I looked at these two pictures. I mean, how can you tell it apart? But Mumbai's on one side, Lagos on the other. And while many urban areas are malaria-free, some of our biggest, most complex urban areas are not. And these are two of those areas. And the systems we need to deliver healthcare in a Lagos and a Mumbai is not the same as what we need to deliver in a rural area where many of us have focused our careers. Infrastructure projects. There are so many of these around the world, and health is not built into these from the beginning, and yet the health effects that they have are profound. How do we do a better job as a health community, as a global health community, to interface from the get-go in infrastructure projects and do the sort of scenario planning that's required and make sure that we don't get caught by surprise once those projects are underway? So a few concluding thoughts on the malaria part of this talk. I'm a very bad artist. I got stuck at the stick figure level in about 2nd grade. So this was me on a mouse in October last year. But, you know, when I think about malaria at the beginning in 2000, and you look down into that sea, there was just water everywhere. There was malaria everywhere. You couldn't see the bottom. So we really had a one-size-fits-all approach. You know, mosquito nets, spraying, diagnostics, drug, let's just get it all out there. But as you drain the pond, as transmission drops, you start to see the bottom. And there are places where we're malaria-free, where diagnostic testing has shown us that, in fact, we were already malaria-free, and that what we were treating as malaria wasn't malaria in the first place. And so now we have a picture of the bottom. And we need to start using those data. And this is an example, a very nice example of microstratification of malaria done in Lao PDR. And you can see that they've gone down to a very granular level here of having data to show where is their malaria burden. And we need to now figure out, how do we use that data for program management? How do we use the scarce resources we do have most efficiently? And it's not just snapshots of one point in time, but it's trends, right? It's how do we see what's happening at the local level over time, and how do we respond? If a place is stuck, how do we figure out what additional tools to bring? If it's continuing to go down, how do we make sure those resources keep flowing to doing what they're doing? Here's an example of how that's going to play out in Africa. This is a new policy that emerged last year out of the Malaria Policy Advisory Committee. It's called Seasonal Malaria Chemoprevention, or SMC. It's very simple. Take two old drugs, amidiaquin and SP, put them together, give them monthly to kids under 5 during the transmission season, 75% protective efficacy. If we had a vaccine that was 75% efficacy, it would be front page news. This couldn't even get anybody to cover the story, right? Because it's old drugs. And you can't use it everywhere. This is not a magic bullet everywhere. This is useful in the Sahel sub-region of Africa, right? That bar across the map. But in those places where it's useful, 75% reduction is going to make a lot of difference to a lot of people. And this is the leading edge of what I think is happening. We're not going to get magic bullets coming down the road. We're going to get interventions that are useful in specific sorts of settings. And we're going to have to piece that puzzle together to get where we want to go. And what we need are countries that are able to look and think about a toolkit to design their investments in malaria. At the heart of that, the square box in the center, is a malaria program review. It's getting out there and looking at the program, looking at the epidemiology, the entomology, the data, the program coverage, looking both qualitatively and quantitatively at what's working. Within that, we then need to have an umbrella strategy. That's the Global Malaria Action Plan from the partnership, technical recommendations from WHO, which is sort of the foundation, and then pieces that countries can draw on. Quality assured commodities, gap analysis tools, costing, how do you cost a program? And through that, you put together an investment case on a country-by-country basis. I'm going to finish the malaria part thinking beyond malaria. You know, we all think about global health, and yet a lot of what we do in health is affected by everything else that's happening in development. So here I give the example that malaria control over the last decade is like compressing a spring, right? And we've done a nice job. That spring is compressing. But if we disinvest today, that spring will spring right back. In fact, it will travel, as we all know about springs. When they spring back, they actually go past where they started, right? And we'll lose ground before it'll settle back to pretty much where it started. So if we want to make durable progress while we're compressing that spring through our control measures and saving lives, doing good work, the built environment needs to change. The environment that allows malaria to not exist, the sort of durable development needs to happen. You know, CDC started as a malaria control center for the United States. And we did a lot of great work, we at CDC, long before we were born, but did a lot of great work. But a lot of what happened in the South of the United States had nothing to do with public health per se. Screening windows and doors, better access to health care, those sort of basic building blocks probably did as much to get malaria out of the South of the United States as did anything we did in public health. So I think as a community, we need to pay attention to what's happening in development outside of health. And I think sometimes we don't invest enough time in looking at all those other pieces of the development puzzle and how they fit together. I encourage people to think about the post-2015 agenda. It is a super complicated process. I have been in more meetings on this, and I still don't understand all the moving parts to this. But that's not a reason not to try. And I think we all need to figure out. This is health in the post-2015 agenda. This is an effort that's been led by WHO and by UNICEF. And, you know, people seem to be coalescing around the idea of universal health coverage, healthy life expectancy, some very broad goals. But we need to pay attention to that, and we need to pay attention to what will happen to the other goals, and how will those affect all the efforts that we want to see happen in global health. One of the things that's driven me crazy in the malaria community over the 15 years I've been a part of it is our ability to be our own worst enemy. And I guess that's probably not specific to malaria, but I'll give the malaria examples. I constantly see us arguing over things that I think are hollow debates. Should we be focused on Africa or outside of Africa? New tools or existing tools? falciparum or vivax, attacking the vector, attacking the parasite, saving lives today versus eradication tomorrow. Those are clearly silly debates. We need to be doing all of these things. And I urge you in your careers, for those of you especially that have a lot of your careers ahead of you, to really avoid these things, to think through, to find compromises and realize that if there's a dichotomy set up, it's probably a false one. These kids are counting on us. Thanks very much.